Thank you to Sally and the team for putting together such a timely and practical workshop on this topic, and for inviting me to speak on my experience in delivering lymphedema care within the global program to eliminate lymphatic filariasis. I hope that at some point during this presentation you'll have a moment of connection or inspiration that you can take back to your own circumstances, because I do believe that there's a lot we can learn from low-income countries which are mandated to address filariasis-related lymphedema as a public health problem. LF is a parasitic disease where filarial worms inhabit the lymph vessels, hence the name lymphatic filariasis. The microfilaria are transmitted by mosquitoes between human hosts, and the mature worms create nests in the vessels afferent to lymph nodes, where they interact with immune elements and alter the function of the lymphatic vessels. Over time, the vessels become dilated, cease pumping, and the classic signs of lymphedema appear. Mostly in the lower limbs, but as we know, lymphedema can occur anywhere. It just depends where the worms establish their nests. Podoconiosis is lymphedema caused by long-term exposure to irritant soils. And as it is often co-endemic with LF, and since clinical management is essentially the same, the WHO recommends that people affected by podoconiosis are included in the LF morbidity management program. As a vector-borne disease, prevention in the LF program is annual mass administration of preventive chemotherapy, whereas in podoconiosis, the intervention is to wear protective footwear and minimise contact with the soil, and that should prevent new cases. LF and podoconiosis disproportionately affect people in rural and impoverished areas of Africa, Asia and the Pacific. Altogether, an estimated 20 million people in over 70 countries. Their families, and indeed their whole communities, are all adversely affected by the disability, the stigma and poverty associated with lymphedema. But delivering lymphedema care into these often remote and inaccessible communities takes innovation, inclusivity and cultural sensitivity. And it also needs low-cost interventions that can be managed and sustained in a community-based home care model. And I'm briefly going to mention hydrocele here for context, as it is another significant LF-related morbidity and is included under the umbrella of the LF MMDP program. The intervention is surgical and curative, so it's very different to the clinical requirements of those affected by lymphedema. And it's these two disfiguring diseases, hydrocele and lymphedema, that were the impetus behind the global program to eliminate lymphatic filariasis. And over the last 25 years, there's been a 74% reduction in global infections. And most countries are pretty well advanced with the mass drug administration program. But that's only half the job, and the morbidity management and disability prevention program provides treatment and ongoing care for people with existing disease. But this part of the program is much less well advanced in most countries. For countries to validate elimination of LF as a public health problem, they must demonstrate MMDP implementation, which includes registering all cases, providing surgery for the hydrocele cases, and community-based training and support in self-care for lymphedema. This focuses on hygiene, infection prevention, and some simple exercises. The ultimate goal is to integrate lymphedema management into existing health services, and it's disappointing that this is not required at the point of validation. So how do you deliver training and support into some of the world's most remote and inaccessible communities? Well, in each country there is a Ministry of Health, which delivers a variable level of secondary and tertiary health services, most of them in the metropolitan areas. Under this Ministry of Health umbrella, a department to eliminate LF will be established to carry out all the global program requirements towards validation, including those related to the morbidity management program. The validation dossier requires countries to survey all endemic or historically endemic regions to inform the level of service delivery that's required, and there has been considerable effort taken to register known cases in many countries. Cascade training is then used to deliver the lymphedema education and management program, and there may be several layers of training before the cascade reaches the end user. Primary healthcare at the community level is commonly delivered by a semi-literate health workforce, who are frequently expected to deliver multiple programs with scant resources. So implementing these programs is logistically challenging, but they're also socially challenging. And local misinformation, superstition, and persistent stigma all conspire to limit access and prevent people from registering at the health facility. Yet despite these constraints, some countries have managed to deliver life-changing programs to many communities, highlighting that effective lymphedema care is as much about community acceptance as it is about the clinical interventions themselves. Without being included within the validation dossier, there may be less impetus to achieve the end goal, which is continuity of care via integration of morbidity management services into the mainstream health system. But that doesn't mean that it's not being done. And Bangladesh is the first country to fully integrate LF-related lymphedema care into its mainstream health services. This means that providing lymphedema education and support is a core role of all health staff involved in primary health care. This ensures that families and communities can access appropriate support at their local facility. In Ethiopia, the MMDP program worked closely with NGOs and universities to develop a simple surgical training device, and then introduced hydrocele surgery into the national surgical training curriculum. A strategic move that ensures that post-validation surgery isn't dependent on foreign specialists and just becomes part of the health system's normal operations. Until recently, lymphedema management was constrained and limited by the vertical nature of the LF elimination program, where funding and planning are determined and delivered within a disease-specific model. More recently, the common nature of community-level interventions for a range of NTDs such as Buruli ulcer and cutaneous leishmaniasis has led to the development of a cross-cutting model known as integrated skin NTDs. And these integrative efforts build system-wide resilience and efficiency, and they also help to engender local ownership of the program and clinical knowledge which can be applied to a broader range of the community and not just a small segment for a single disease. So how does this relate to us in Australia and New Zealand? Well, Australia is the 12th largest economy globally in terms of GDP, and the 9th highest in terms of GDP per capita, yet we are 35th in achieving the Sustainable Development Goals. And when it comes to lymphedema care, we're still very fragmented. Patchy data, variable service availability, and limited integration across disciplines. So here's where I think we can get some lessons from our LF and podoconiosis colleagues. First of all, we need to establish a national registry of all lymphedema cases from all causes. You can't manage what you can't measure. This involves training all primary health staff in understanding the risk of lymphedema, basic skills in identifying clinical signs of lymphedema, providing easy reporting mechanisms and access to appropriate referral pathways. A population-based registry would not only support efficient service planning, but enable better research and benchmarking of clinical outcomes. So can we define and provide an essential package of care that is relevant to the Australian and New Zealand setting? One that will capture all cases and integrate lymphedema care into routine health systems? One of the things that I observed a lot in the global program is the devastating effect of relying on a top-down model, where a lot of resources are spent describing the problem, but in the meantime, people wait for government services that may never come. In many countries, self-care groups have filled in this gap and been instrumental in community ownership of the solution. Mentoring between individuals can be cultivated with just some simple infrastructure, and in Uganda, the grandmother seat is provided where older women who've got a lot of life experience will come and sit, and it's a literal and metaphorical place for shared wisdom, care and dignity, where anyone can come and ask for advice. In Fiji, the Ministry of Health share important health messages in short TikTok videos, so we can also enhance modern technology to help us reach some of the previously inaccessible places. So in order to embed lymphedema education and identification into primary care, it needs to be embedded into the medical and nursing curricula, taught as a core subject in allied health training, and added to broader non-communicable disease management guidelines. If we can find a way to adopt a multi-sectorial approach, identifying cases through podiatry services, aged care, wound care, speech therapy services, then perhaps we can build local support networks through community engagement, peer mentoring, and culturally safe care coordinators. In closing, I'd like to say that people managing LF and podoconiosis-related lymphedema in the world's most underserved communities can teach us powerful lessons about resilience, inclusion, and the flow-on benefits of cost-effective innovation. They show us that with community engagement, a focus on function and dignity, and a consistent system support, we can transform lives even in the absence of high-tech tools. LF endemic communities view lymphedema management as a community endeavour, one rooted in equity, empowerment, and the belief that every person deserves to access care, no matter where they are or where they live. And there's a call to action that's frequently used in NTDs, which I think fits well here as well. And that is to end the neglect and leave no one behind. And this is also the goal of the LKN Foundation, and I invite you to view more of our work and resources at the LKN website. Thank you for your attention. I hope there was something useful or interesting in it in my presentation for you.